We want to look at their chief complaint and apparent life threats. This is what I was mentioning earlier with the gentleman where he was laying on the floor with blood on his arm. We want to look and see if that bleeding is very rapid. We need to address that because that's a potential life threat. With this picture, we see this individual laying on the ground. Doesn't appear to be moving, doesn't appear to be conscious. Eyes are closed, and it appears to be there's some sort of injury on the forehead. It's important to remember that the chief complaint is whatever the patient tells you is wrong. You may actually find different things wrong with them after this, but their chief complaint is whatever they tell you is wrong. Stable versus potentially unstable versus stable. So this is important to determine right away. Are they stable? Are they potentially unstable? Or are they stable? And we will talk more about this as we move along, and you'll learn to put these in better context as we learn about a variety of medical and traumatic conditions. So some examples of life threats are airway obstructions, respiratory failure, respiratory arrest. And we'll see some examples of respiratory failure here in a little bit. Are they in shock? Is there severe hemorrhage? Are they in cardiac arrest? So as we move on with our primary assessment, we look at what are the potential life threats of this patient. So you see this patient lying on the floor. You see blood running on the floor. And so there's obviously been some type of penetrating type injury. So we want to address any of these life threats. So with this particular patient, if this is coming from a leg, for example, then we may want to apply a tourniquet. Again, it depends on how rapidly this patient is bleeding. If the patient is unresponsive, in most cases, follow the ABC sequence: airway, breathing, circulation. And I say most cases because if it's a cardiac arrest, that will change slightly. So airway, is our airway open or is it patent? You'll hear that word patent a lot. It just simply means, is it open? Are there any signs of airway obstruction? So as we look at the individual in this picture, it appears that he's had a facial injury. There's swelling and bleeding from the nose, and we see the swelling to the nose, possibly maybe a fractured nose. So is this creating an airway obstruction? We can also bleed from the nasal passages, and it's connected to the back side of the mouth, so that blood can run on the inside down into the mouth and create an airway obstruction as well. So again, we want to pay attention to that. So if the airway is not patent, we're going to move on to breathing. I'm sorry, let me back up there. If the airway is not patent, then we're going to open the airway and then reassess. If it is patent, we're going to move on to the breathing aspect. So as we assess breathing, are they breathing? Are they breathing at all? Is there chest rise? Is there adequate ventilation? So is there normal chest rise? Is there very little chest rise? Again, that's very important to know. If they are breathing, then we move on to circulation. If they're not breathing, we provide artificial ventilation and then reassess. We provide appropriate oxygen therapy. Oxygen therapy has changed over the years, and so we will be talking about what is appropriate and what is not appropriate. As we move on to circulation, we control any major bleeding that we see, such as in the earlier picture with the gentleman with the bleeding from the arm, or then the other picture with the bleeding from the leg. We check for a pulse. Do they have a pulse or don't they have a pulse? We assess skin color, temperature, and condition. This is going to tell us if circulation is adequate. when we assess our skin color, if the skin appears slightly bluish or purplish or even pale, then there is less than adequate circulation. Their temperature may also be cooler than normal with inadequate circulation. If no pulse and no spontaneous respirations, then we begin CPR. With circulation, we check capillary refill. We can check capillary refill by taking a fingernail that doesn't have any type of nail polish on it, and pushing down on it slightly, pushing the blood out, seeing how quickly it comes back to normal. And that should be less than 3 seconds. Then we evaluate the time that is needed to restore that blood in that capillary system. Like I said, that should be about 3 seconds. Here's an example of that. So the nail should restore its normal pink color within 2 seconds or less than 3 seconds. If the patient is unresponsive, we want to follow the CAB sequence, or compressions, airway, and breathing. The CAB sequence is more of a management sequence for cardiac arrest. We verify unresponsiveness. If yes, then we send someone to get the AED and call for paramedic help. We assess for breathing and pulse at the same time, no more than 10 seconds. If no breathing and pulse, we begin chest compressions. The American Heart Association has a BLS algorithm which simplifies the CAB sequence. As we start from the top, we see that we verify scene safety. If our victim is unresponsive, it details what to do there. As we move down, we can see that in the center red box, we look for no breathing or only gasping, check for pulse, simultaneously no more than 10 seconds. The algorithm gives us a branching point. If they have going to the left, if they have normal breathing and have a pulse, then we monitor until emergency responders arrive. Or if we're transporting, we would go ahead and treat for what we can and transport. To the right, it says no normal breathing, has pulse, and it goes through to highlight the CPR sequence. And as we can see, we can move on down through that algorithm. So what about unresponsive patients? With unresponsive patients who have a pulse and are breathing, it's important to open the airway with the head tilt chin lift for anyone with no chance of spinal trauma. So this is shown in the picture on the top with one hand on the forehead, one hand on the bony part of the chin, and we extend the head to open the airway. This lifts the tongue off the back of the airway that can block the airway. We open the airway with it's called the jaw thrust, head tilt jaw thrust, and when there is trauma suspected, we use the modified jaw thrust technique, which is shown in the bottom picture, and we will go through all of these in class, but the modified jaw thrust is the responder, the EMT is behind the patient, and you're pushing up on the bottom part of the mandible, which again will raise the tongue up off the back of the airway. Some common reasons for airway obstruction in unresponsive patients include the tongue, as I've mentioned, trauma to the face, trauma to the neck, blood. Again, this would be coming from trauma, or could be coming from a nosebleed. A lot of people, especially maybe some older people, have problems with having nosebleeds. Could be a foreign body in the airway. Signs of breathing difficulty or effort to breathe are retractions, use of accessory muscles, nasal flaring, 2 or 3 word sentences, tripod position, sniffing position, and we will see all of these here shortly. So respiratory distress versus respiratory failure is very important to determine, and we will talk a lot more about this in respiratory and airway management, but again we're going to start mentioning it here with the primary assessment. So respiratory distress has an increased work of breathing, which means that someone is working harder to breathe than they normally would. And they have an increased effort and rate as well. So they're going to be working hard. So this is when you might see someone's chest really heaving to try to breathe. They're using accessory muscles, which we'll see here in a minute. They're breathing usually faster than what they would normally breathe. Respiratory failure, on the other hand, is respiratory effort and or ventilation that is inadequate to meet the oxygen demands of the body. Anyone with respiratory distress needs immediate treatment to prevent that from becoming respiratory failure. Anyone with respiratory failure also needs immediate treatment, but they are at the next step for them is respiratory arrest, and we really want to try to prevent that if we can. With respiratory failure, homeostasis can no longer be maintained. And homeostasis is the condition of the body trying to maintain itself with chemically and biologically within the body. The body becomes very hypoxic with respiratory failure. The body can also be hypoxic with respiratory distress as well, but it gets extremely hypoxic with failure. So we're going to watch a video here. This is an example of respiratory distress, and there will be sound in the video, so I'll let the video here talk for itself.
Most likely, yeah. We'll see. Sometimes the pediatrician, depending on who's on, they might say, no, we can treat this here, and then if he doesn't improve, then we'll transfer him out.
Hello there, Dr. Carlo Oyer. In this video, we're going to see a very clear example of respiratory stress. This patient had clear intercostal retractions, which is when each patient takes each breath, you can see the ribs coming out underneath the soft tissue. And this is just a superb example of intercostal retraction. But he also had suprasternal retractions as well, which we'll see in the video.
So this is what we call suprasternal retractions. You see the soft tissue becomes more prominent every time he breathes because it's pulling. These are what I call intercostal retractions. Every time he breathes, we can see the ribs. And those are obvious signs of distress. And of course,
So with this video, we're going to see, with this infant, we're going to see nasal flaring. You'll also see retractions as we saw in the previous video. But in the first few seconds of this video, I'd like you to watch the nose and the nasal passages, and you're going to see them opening and closing. And this is an example of very classic respiratory distress. Adults can have this as well, but it's very noticeable many times with infants and children. So continuing our primary assessment, we want to determine patient priority and make treatment and transport decisions. If multiple patients, we want to use the incident command system and triage. If only one patient, determine if the patient is a priority patient. This is determined by looking at their ABCs. So we always want to manage ABCs before transporting. So any problems with the airway, breathing, or circulation, we always want to start treatment before we transport. If it's something that we can actually complete before we transport, that's fine too. High priority patients include the following: any patient who is unresponsive, who has a poor general impression, they have difficulty breathing, they have uncontrolled bleeding, or altered mental status, severe chest pain, signs of poor perfusion, and any complicated childbirth. Major trauma is also included in this category. Some patients have very time-sensitive conditions. Some of these are ischemic chest pain. So ischemic chest pain is when there's a blockage in a coronary artery and the heart isn't getting enough oxygen, so it becomes ischemic. So this is important that that these are time-sensitive patients. We want to begin treatment, but we also want to get them moving along to the hospital or to intercept with paramedic care when possible. Suspected stroke is very time sensitive, as well as major trauma and amputation of limbs. All of these need to be in the hospital to be definitively treated. So the ischemic chest pain, they likely will need a cath lab. Suspected strokes, they will likely need to have a CT done, and then probably have some thrombolytics or possibly some sort of intervention. And then major trauma, EMS is not the fix for major trauma. That's done in a surgical suite. And then, of course, amputation of limbs are time sensitive because you're going to have major bleeding. First of all, but then second, you're looking at the amount of time necessary from the actual injury to be able to possibly reattach those amputated limbs. So with our primary assessment, we have our destination determination. So this is important because it is important to take a patient to the most appropriate hospital. One thing to keep in mind is that the patient has a right to make a choice as to where they want to go. However, most of the time, we can influence that considerably. In Indiana, with traumatic patients, Indiana has adopted the Centers for Disease Control Field Triage Decision Scheme. And so we're going to go through this and talk about this briefly. So you'll notice that there were 4 steps to the Field Triage Decision Scheme. This is showing, this is showing steps 1 and 2. You can see that the step 1 is vital signs and level of consciousness, and there's factors there, specific factors that we need to look at. And then step 2 are anatomical type injuries. These patients should be transported to a level 1 trauma center. In step 3, we see some mechanisms of injury. If a patient is not applicable to step 1 or step 2, then we look at step 3, which are the various types of injuries, such as falls and the distance that they fell, both adults and children. High-risk auto crashes, which is a lot of intrusion into the vehicle, ejection, a death in the same passenger compartment, or vehicle telemetry data that is consistent with high-risk injury. There's motorcycle crashes and automobile versus pedestrians as well. So this is step 3. And we will talk a lot more about these when we talk about trauma, but these are things to keep in mind as you're doing your primary assessment. And then step 4 looks at special patient or system considerations with older adults, children, patients who are on anticoagulants or have bleeding disorders, patients with burns, pregnancy that's greater than 20 weeks, or any other patient you think may need to go to a trauma center. Excuse me. So steps 1 and 2 definitely need to go to trauma centers. Step 3 probably does need to go to a trauma center as well. And then step 4, if your patient fits into any of these categories, they also need to go to a trauma center. So like I said, we'll talk more about the field triage decision scheme and the Indiana statutes during our trauma portion of the class. So write down any questions you have and bring them to class.